Good morning, everyone, and thank you for joining today's Garvan virtual seminar. My name's Tilley, and I'm privileged to be the director of the Garvan Research Foundation, the fundraising and marketing arm of the Garvan Institute of Medical Research, and I'll be your MC this morning. Now, first off, apologies from Garvan's Executive Director, Professor Chris Goodnow. He is taking just a couple of very well-deserved days off and sends his apologies and wishes he could be here with you. In his place, however, we're very lucky to be able to welcome Associate Professor Phan. Is one of Garvan's clinician scientists, a mighty job that they do, a senior member of our faculty, and he'll be here giving you the introduction to today's session. Now, please don't get nervous. I will just let you know that we do have the chairman of both the Institute and the Foundation in the audience today, so we best both be on our very best behaviour. On the panel, we have Priyanka Kalkani, who many of you will know from our public tours when we could conduct those safely, and our in-person seminars. And Priyanka, along with Joseph Hewitt, will be in the background supporting us today. So if you have any technical issues, please don't hesitate to enter that into the chat function, and Priyanka and Joseph will reach out to see if they can help you. In terms of the scientific talent, you're in for a real treat today. Our key speakers are Dr. Alyssa Kane and Dr. Sara Wahlroos. Both, like are clinician scientists, so they have appointments both at the Garvan Institute and at St Vincent's Hospital. And I think that individuals such as Alyssa, Sara and indeed are a really wonderful example of the power of the St Vincent's Hospital campus, and the fact that because we're so close, and indeed the Garvan was founded by St Vincent's Hospital and the Sisters of Charity, we can really fast track those scientific innovations into the clinic and ensure that our research is being driven by clinical challenges. I will just mention that I think we have one of our incredible sisters in the audience today, Sister Annette. If you're there, welcome. We miss you in the building. We look forward to seeing you as soon as we can. So before we start the official proceedings, I would like to take this opportunity to pay my personal respects to the Gadigal and the Gundungurra peoples, the traditional owners of the lands on which both the Garvan Institute is located and our Mossvale facility, Australian Bioresources. And I would like to recognise the continuing connection to land, waters and culture, and pay our respects to their elders past, present and emerging. Thank you. Australia's response to COVID-19 has been nothing short of remarkable. I think that we would all agree that we've handled it exceptionally well, with thanks to the government's willingness to really take on board the best scientific and clinical advice that our Australian specialists have brought to the table. However, the situation unfolding in Melbourne does give a worrying sign that, and perhaps a little bit of a reality check, that this situation is unfortunately far from over. So with that in mind, a big shout out to the individuals working on the front line, particularly our doctors and nurses, but also everybody who's out in the community providing core services. We take our hats off to you. Finally, I'd like to give my sincere thanks, enthusiastic thanks to all of you in the audience. Garvan would not be the institute that we are without the support of the community. And so to our donors, our advocates, our partners for the future, we are humbled by your continuing commitment, particularly during this challenging time. Thank you from the bottom of all of our hearts, and on behalf of all of our scientists who are just overwhelmed by the support that you give and the interest that you show in Garvan's medical research. So in terms of the format for today, it's a little bit different to what we've done over the last, excuse me, that's not COVID-19, I can assure you. Over the last couple of sessions today, we're going to mix it up a little bit. We'll have an introduction from we'll have a live improvised Q&A with Alyssa and Sara before we open up to your live questions from the audience. So for those of you unfamiliar with Zoom, you will note that there is a Q&A function at the bottom of your screen. Please feel free to type in your questions as they come up for you, and I'll certainly do my very best to get through all of those questions before we conclude today's session. Now, it is coming up to the end of June, which is frightening. And so that for us means end of financial year. And again, thank you for all of those incredible donations that we've seen coming in recent weeks. It's also the beginning of a real thrust for the flu season. Putting aside COVID-19, we have a big challenge just with the normal flu at this time of year. Now, I myself, along with more than 11% of the Australian population have asthma. So I have always been a very enthusiastic recipient of the flu vaccine. And we know that that is particularly important in the times of COVID-19. So that's just a little bit of what we're going to discuss today. So without further ado, it's my great pleasure to now introduce Associate Professor Phan to give us an introduction on comorbidity and some operational measures Garvan has taken to safeguard our people and our patients against COVID-19. Tree is head of the intravital microscopy laboratory at Garvan and a clinical immunologist at St Vincent's Hospital. He studied undergraduate medicine at the University of Sydney and completed a double fellowship in internal medicine and pathology. Very talented and ambitious. Tree is an expert in the immune system and how it impacts human health, and is going to begin explaining how to manage COVID-19 during the flu season, or if you're immunocompromised, before we welcome Sara and Alyssa to the Q&A. So please join me in welcoming Associate Professor Phan. Tree, over to you.
Great, thanks very much, Mara-Jean. Welcome everyone, and thank you very much for joining us today. I just want to echo Mara-Jean's comments. I think we've been very fortunate in Australia, and it goes to show once again that we really are the lucky country. But, you know, along the way, we've really made our own luck this time, and we've all contributed very much to this. We've all had a role to play, and I think, you know, the wider Australian community has done a great job in terms of following the measures put in place by the government, particularly social distancing and following the rules. And, you know, as Mara-Jean mentioned, we've been very fortunate because we've seen, we've made quite an impact on the pandemic within Australia. A few little forest fires here and there, but hopefully these will get under control soon. But one of the problems has really been with this pandemic, the issue of who is at real risk. And the fact is that, you know, it's not a fair disease. It seems to discriminate. It seems to particularly discriminate against the elderly, you know, against males, particularly males possibly with baldness. And it particularly discriminates against people who have pre-existing medical conditions or comorbidities. So, you know, one of the things that we really need to understand then is how do we protect these people who are at particular risk? And the immune system is really important in fighting infection. But one of the problems is that within us in the wider community, we have a lot of people whose immune systems are compromised, either because through just bad luck, they may have a genetic defect that means that immune system doesn't work very well, or more commonly because they have comorbid conditions that impact on the ability of their immune system to fight disease. And it's, you know, part of our responsibility as a community to protect them by reducing the prevalence of the disease. So particularly with COVID-19, it seems that the sort of conditions that might give you a much higher risk of getting severe disease are things like high blood pressure, obesity, diabetes. A lot of these conditions are things that also increase in elderly people. And at the same time, while we are putting in place all these social distancing measures, it's also important to recognize that this places an enormous burden on individuals in terms of how you cope with the anxiety, how do you deal with, you know, being isolated, being removed from your normal social supports, and also, of course, the sort of effects that can have on your mood and on depression. So these are all really important considerations. And I think it's important to recognize that while the Garvan Institute is known as a medical research facility, and we're very proud of our history and our tradition in medical research, we also at the Garvan are part of a wider community. We're part of the St. Vincent's campus with the hospital next door to us, but also we have clinical spaces within the Garvan, and we have a responsibility to make sure that within these clinical spaces, where we treat patients with cancer, diabetes, the sort of things that, the sort of comorbidities that would place you at much greater risk of getting severe disease, that we take our responsibility seriously. And I'm glad to tell you that the Institute's been very lucky because we've had a fantastic COVID-19 working group that's been meeting daily and dealing with the challenges, logistics and otherwise, of how to make sure that our working spaces are safe and COVID-free, so that people with these conditions who still need to see their doctors and still need to get their medical care can do so safely and with confidence. So, we are part of the community, and one of the great things about the Garvan is that we are very much also dependent on the community. And as Mara-Jean mentioned before, we're very, very grateful for your support. But, to continue to do the good work that we do, then I think it's really important that we encourage you to, see what you can do to help us in our endeavours. And, if you can see some way in which to make a small contribution to our research and clinical efforts, that would be really, really wonderful. As Mara-Jean says, our work is actually really pretty much driven by our community and our community's needs. So your support is really vital. Okay, I might hand it back to Mara-Jean.
Thanks, Tree. That's great. I'm just going to ask you a quick devil's advocate question off the script. I've had a couple of people, a couple of our supporters reach out and ask, does COVID-19 mean that Garvan has had to put our other research portfolio on hold? And I've been quick to reassure them that is certainly not the case. But can you just comment on that? We've got 4 very diverse research themes across the Institute. I guess I'm just looking for your reassurance that we're not only doing COVID-19, we're still investigating all of the diseases that indeed have the worst impact for individuals with COVID-19.
I think that's a really, really good and really important point. I think, as you mentioned, Garvan has 4 really amazing research themes. And while we've been in lockdown and people have been encouraged to work from home, these themes have all been, doing their very best to continue to maintain the sort of pace of discovery that they've been able to achieve in the past. Garvan has not pivoted at all to purely COVID-19 research. What has happened, though, is that we certainly have a responsibility, given the sort of know-how and expertise that's within the building. We're really, really well placed, and some may argue in some circumstances, we're really the best placed institute to pursue some of the lines of research that's needed to help combat the pandemic. But what's really important is that, as you mentioned, part of the problem is that patients who are getting sick are the patients with comorbid diseases. So it's really important, for example, that we continue to drive the research that underpins us dealing with, the medical problems that arises and causes of things like obesity and diabetes, the sort of problems that, are common every day, what some people might call, lifestyle problems or health problems. So that's all continuing and continuing in the background, perhaps not getting as much as attention as it should be, but it's certainly definitely still continuing.
Thanks, Tree. Now, I'm going to be cheeky and do what we ask our audience not to do, and that's to try and get some free clinical advice for myself. So I mentioned I have asthma, and I know a lot of people do. Am I at greater risk of getting COVID-19 or having a particularly adverse reaction to COVID-19 from your understanding?
Yeah, look, so there's two parts of that question. Are you at greater risk of being infected with COVID-19? I think your risk would be very similar to other people. The problem is, on the other hand, if you were to get infected, having a respiratory condition places you at much greater risk of having a severe disease. And a lot of that relates to the fact that your reserve, your capacity to cope with the demands of dealing with that infection is compromised. So absolutely. And that's the sort of reason why, one of the best ways to deal with this pandemic is just to shut down the spread.
Fantastic. Thanks, Tree. Send me a bill after the seminar. All righty. So we're going to open up now and welcome Alyssa and Sara to the panel. Hi, Alyssa.
Hi.
Hi, Sara.
Hi.
Thank you so much for joining us.
Thanks for having us.
Such a pleasure. So just to quickly introduce Alyssa and Sara. So Alyssa is a scientist in Garvan's lymphocyte signalling and activation lab and a clinical immunologist working at 2 major Sydney teaching hospitals. Alyssa, if I'm right, I think that's both St Vincent's and Liverpool Hospital?
Yes, that's correct.
Right. Alyssa specialises in the care of patients with immune disorders, including autoimmune conditions and genetic immune disease. Sara graduated medicine from the University of Sydney in 2009. She's a medical oncologist at Sydney's St Vincent's Hospital and is currently on the home stretch in completing her PhD in breast cancer research in Garvan's Connie Johnson Breast Cancer Research Laboratory. Sara is investigating the effects of exercise on breast cancer biology with the aim of introducing exercise as part of breast cancer treatments in the future. We're so excited to have you both, and Sara, wishing you the best of luck to get to the end of that PhD. So a couple of questions just to kick off the conversation, and I'm going to point this one to both of you actually. So you've both been working in the hospital whilst continuing your scientific research. What has it been like in your experience? Have you been close to the COVID-19 wards? Have you identified any challenges that are emerging because of COVID-19? For example, people perhaps not attending their routine appointments. Alyssa, let's start with you.
Sure. I mean, I think in the early days, there was a lot of uncertainty. It's a new virus. We were getting a lot of reports from overseas about the severity. And as a clinician who primarily looks after patients with immunodeficiencies, whether it's genetic or because they've got autoimmune disease and we've put them on immunosuppressants, we're actually very concerned for our patients and how this new virus might affect them. So there was a lot of planning at the beginning, and we really focused on how we could work with our patients to keep them well. So early measures were things like encouraging the social distancing and moving to telehealth medicine. And in the background, we've also been looking at resources and how we would deal with any issues of resource shortages. And fortunately, really, our numbers have been fairly well controlled, and we're very, very pleased with that, but definitely there have been concerns.
Thanks. Sara, how about you?
Yeah, so very much like, Alyssa, I also deal with immunocompromised patients, obviously undergoing chemotherapy, primarily for breast cancer. So in our center, we had similar types of planning with lots of, stage 1, 2, 3, 4, depending on how the pandemic would sort of evolve, I should say, in Australia. And we're very lucky that our cancer center is separate to the main hospital, which I think makes a big difference in terms of keeping our patients sort of separated from sort of the main patient population in the hospital. So we have, very much like Alyssa, we transitioned into telehealth. But as the control of the virus has been very well handled throughout Australia, and particularly in New South Wales, where the numbers were quite high initially, we've now transitioned back into seeing patients one-on-one to some extent. So overall, I think we've done really well, like Tree was saying in the beginning, but it's a little bit, watch this space because we don't know what's going to happen as the restrictions lift. So we're still on alert, but yeah, overall, I think things changed in the beginning and now they're slowly transitioning back to normal.
Without taking too much of a segue, have you found that your patients have been exercising more or less during COVID-19?
There's a bit of a mixed bag, I have to say. I think the ones who were exercising, going to gyms, etc., have found other alternatives. But I feel like walking has been something that a lot of people have been taken up because I think they were going a little bit sort of stir crazy sitting at home looking at their four walls. So that's been encouraging. But there've also been, you know, a sort of a proportion of patients who haven't left the house at all because of fears of any way of getting, you know, infected. So there's been a bit of a mixed bag, I should say.
Okay, thanks for that. Alyssa, I'm going to throw this next one to you. Sorry, I've jumped ahead. Alyssa, what is the seasonal flu and how is it different to COVID-19?
Well, the seasonal flu is a respiratory virus, and there's several different types. There's A, B, and C, and the type A influenza is the one that seems to cause us a lot of trouble. It tends to be worse in the winter. It comes around and it causes a very similar illness to COVID-19 in that people get the respiratory symptoms, difficulty breathing, fevers, muscle aches and pains. So it can present in a very similar way to COVID-19, but there are some significant differences. Obviously, COVID-19 or SARS-CoV-19, which is the virus that causes COVID-19, is a different virus. It's a coronavirus. Some of the key differences that concern us is its infectivity. So it tends to spread a lot more than the regular flu virus. So typically we think of, you know, each person with flu may be infecting 1 or 2 people, whereas coronavirus maybe 2 or 3 or even more as the numbers are coming out. So that's obviously very different and causes more significant clinical illness. And the data that's coming out that everyone's aware of is that people seem to get more severe disease and there seems to be higher fatality rates with the coronavirus. So that'll be the key differences.
Forgive my ignorance, but why is flu more common in winter, in the colder months?
Yeah, look, that's a really great question. And I actually don't think we really fully understand why that is. Some of the hypotheses or the reasons that might be is because during winter people are more close together and, you know, we've really focused on social distancing with coronavirus, and it's similar for flu, so it's spread by droplets. So the closer you are to someone with flu, the more likely you are to get it. There may be some features, of course, of the virus itself that makes it more likely to be prevalent during the colder weather as well.
And one more quick question. Can you have the flu and COVID-19 at the same time?
Yes, absolutely. They're both spread in a very similar way. They have similar, you know, clinical features. So the only way you would know is through testing, but there's no reason why you can't have both. Usually though, when people do have a respiratory illness, they tend to only test positive for one, but certainly we've had patients who've tested positive for multiple viruses at the same time. It's not unheard of.
Thanks for that. Sara, if I were your patient and I had to go into the hospital perhaps for a routine procedure, or I had to come to the Kinghorn Cancer Centre for chemotherapy, what advice would you be giving me to keep me safe if I did have to physically come in?
So, I mean, we advise our patient, and the way that our centre is set up currently as well is that, you know, social distancing is really one of the key elements to this, as well as hand washing as you come in. So we encourage all of our patients to adhere to that. And as you enter the centre, as well as the main hospital, you get a temperature check. And if your temperature is elevated, then you're not effectively allowed to enter the centre. And for our cancer patients, I actually had one patient the other day who was mildly febrile, and you know, we had to take her to the emergency department for further investigation. So it's very, very strict. So you're effectively not even allowed to enter in, and that's not to just only protect yourself, but obviously to protect the healthcare workers as well as the patients in the centre. So it's really very similar to the general population in that sense. And obviously, if you're unwell as a patient, you shouldn't even come in that day for anything.
I can confirm I am in the Garvan building quite unusually today, and I got my temperature checked and I got a sticker to say I'm A-okay. That's great.
Yeah.
So, guys, do you think that, you know, particularly I think in Australia, we've had this culture of soldiering on. You know, if you've just got a sniffle, you go to the office, you say, I'm fine, there's nothing to worry about. Or, you know, we kind of tend to not really like to take sick days. Do you think that COVID-19 is going to change culture and practices around coming to work sick?
Yeah, I mean, I definitely, I believe so, at least in the short term, and I think at least until the vaccine comes in, and then it's just about what happens with, you know, human behavior can be predictable at best, so we don't really know what will go on moving forward. But I think from a healthcare point of view, that's been a very, you know, that's kind of the culture definitely in our kind of industry, where you come in anyway, you look after your patients, and you do what needs to be done effectively. And I think that will change moving forward with all of this. And I think looking at other industries, because of the transition that has had to be done with a lot of people moving to home offices effectively and remote, working remotely, I don't think that would be, you know, a bad thing, because you can then just transition and sit at home with your sniffles and do your work from home, which isn't necessarily the easiest thing as a physician. But, you know, I think we will be a little bit more cautionary moving forward, I suspect.
Thanks. Alyssa, I want to just dig in a little bit as to what being immunocompromised is and how an individual might be immunocompromised. Do you mind extrapolating on that?
Sure. So your immune system really is a protective mechanism your body has. It's really made up of your white cells largely, and they're designed to fight off things like infection and cancers. And normally when you have a really good immune system, you probably don't even notice it's there, because it's already done its work and it's fought off all the infections. Periodically you will get sick because some infections do take hold, and then your immune system kicks in and deals with it. Now, the patients that I see have immunodeficiencies where their immune system is compromised, so their cells are not working as well as they ought to. And so this could be due to genetic problems, so these are primary immunodeficiencies, or it could be because of the medications they're on, and we call those secondary immunodeficiencies. So patients with autoimmune disorders like lupus or rheumatoid arthritis, those people can have an immunodeficiency because of their treatment. And what that in practical terms means is that they're more susceptible to infections. So they may be more likely to get an infection or have more severe infection, or be infected with organisms that normally, you know, wouldn't be an issue if your immune system was working well. And one of the problems we have, I guess, as clinicians, when we treat people with immunodeficiency, is that we don't really know which person is more likely to get an infection than others. And that's some of the research that I'm participating here in the Garvan, and that is to look at either genetic factors or cellular factors in patients with immunodeficiencies, whether it's due to genetics or medications, in terms of why certain people are more susceptible to infections than others.
Okay, thanks for that. And Sara, you've made it pretty clear that individuals who are currently undergoing treatment for cancer are certainly at a higher risk than the general population. What about somebody who has recovered from cancer but was exposed to chemotherapy? Is there an ongoing vulnerability to that patient population?
Yeah, so we don't think so, no. I mean, obviously it takes some time probably for your immune system to recover fully after, treatment for any kind of malignancy. And I think the more treatment that you have, being surgery, radiation therapy, and chemotherapy, etc., will have an overall sort of immunosuppressive effect. So even though your blood counts or the white cell counts, like Alyssa or the that she was alluding to, even though that might be normal, there might be a period of time after chemotherapy or after finishing your treatment where those cells aren't fully functioning, but we're not sure about exactly how that works and who that might actually relate to, or who might be more susceptible than others. But overall, we say that somebody who has finished all of their cancer treatment, who are currently not on any treatment for their cancer, have the same sort of immune system or effective immune system that somebody without cancer.
Thanks for that. Alyssa, if I've had the flu, just the common flu, will that weaken my immune system?
Yeah, that's a really great question. I think a lot of people have this feeling that maybe that's something that does happen to your immune system. On the whole, most people who get the flu virus, they'll be unwell for a few days or a week or so, but they recover just fine, and their immune system is just fine. There's nothing that's happened to their immune system. But definitely there are the very small minority of people where they can have some immunosuppression. But on the whole, even if that happens, you do recover.
Okay, thanks. Why, I think I know the answer to this question, but I'm going to ask it anyway, because a friend asked me the other day, why can you still get the flu if you've had a flu vaccine?
That's another great question, another very common question. So the way vaccines work is that you get exposed to a part of a virus or a bacteria, but in this case a virus, and then your immune system has a first pass at it. So it can look at it, and then it builds up something called memory. And what immunological memory is that the next time it sees it, it responds faster and more efficiently, to the point where a lot of people won't even know that they've been exposed and had that infection. The problem with the flu vaccine in particular is that the memory response doesn't last forever. And so it can wane, which is why we have to have annual flu vaccines. And also the flu virus comes in different strains, so there can be slight variances in the structure of the flu, which means that if you get exposed to something that you haven't been vaccinated to, then you may get symptoms, or that if it's a little bit different, then you may still develop some symptoms. But on the whole, patients who have been vaccinated have a lesser response, and they also are not as lesser response clinically, because their immune systems are much more stronger in fighting off the flu, and there's less fatalities associated with people who've had the flu vaccine. So that's why it's so important, and we really encourage all of our patients, particularly our immunosuppressed patients, to have an annual flu vaccination.
And Alyssa, if you have an autoimmune condition and you're not immunosuppressed, and so presumably you have a hyperactive immune system, are you better at fighting off viruses and infections than you would be otherwise?
Yeah, that's also a really good question. A lot of patients ask me about immune systems being up or down, but really the way we think about the immune system is that it's sort of working in the wrong way. So we call it dysregulation. So instead of it doing the right thing, when you have an autoimmune disease, what the problem there actually is that it's no longer able to discriminate between infection versus self. So it's not really about the immune system itself being overactive, but it's actually doing the wrong thing. So in that circumstance, it doesn't necessarily, or it doesn't mean at all that you're better off fighting infections. It just means it's doing the wrong thing. And actually, the more we look at patients with autoimmune disease, we find that there's an association with autoimmunity and with infections as well. So when your immune system isn't working, it can not only recognize the wrong thing, but also not recognize the right things properly, in which case, it's a bit of a double whammy. You have the autoimmunity and the infections as well.
Doesn't sound fun. Sara, I'm really curious about your area of research. Why is exercise important if you're going through a cancer journey?
So, from what we know from mainly epidemiological studies, which is big population studies in people who've had cancer, and then sort of looked at questionnaire-based formats, looking at how much activity they're doing, say on a weekly basis, etc. And then they've, followed these patients up over time and looked at who gets their cancer back, who potentially dies from their cancer, etc. So there's quite a strong evidence for those kinds of studies showing that the more active you are, the less chance of your cancer coming back, as well as you specifically dying from your cancer. And this has been linked quite strongly in the literature to prostate cancer, breast cancer, and colorectal cancer primarily, but there is still associations across most cancers. So I guess that's one reason. And the second thing is that there appears to be certain biological mechanism for this response that we've seen, and that could be part of the immune system boost that you get from not only a one-off exercise session, but also over the long term. But that doesn't only sort of affect the immune system, but also your overall health. So reducing things like coexisting medical conditions that comes often after a cancer treatment because of deconditioning, et cetera, and probably side effects of cancer treatments. So, there's lots of reason. And then quality of life that are sort of indisputable in the literature, that we know that people undergoing physical activity during or after their cancer treatment have a better overall quality of life, and particularly they're less tired, which is one of the main side effects that people complain about with the treatments that I prescribe.
And if you have the flu, in your opinion, should people keep exercising or should they stop?
Yeah, so that's a good question. And I think, not my cancer survivors who would ask me this. I think there's a difference between the term exercise and the term physical activity. So physical activity basically just means that you're expending more energy than what you would just sitting down. So that could be walking, shopping, gardening, or whatever that might entail. Now, exercise is a more structured form of physical activity, as where you do, specific sets or repetitions of something with the goal of improving strength or improving sort of cardiovascular fitness. So they're a little bit separate. So what I say to people who, for instance, have the flu or feel a little bit unwell, it's more about you just do as much as you can. So if that means a little bit of walking, then that's better than just sitting down. And that's maybe not only because of potential immune benefits of exercise, but also because we don't want people to decondition, which will then mean longer recovery, et cetera, et cetera. So I think there's other things that are important aside from just sort of the immune side effects with activity levels.
Okay, so all those people doing personal training in the park near my place are doing the right thing.
They are doing the right thing.
Excellent. I'm going to welcome Tree back to the panel, if I may, Tree. And Tree, I'm hoping that when you're with us, you might comment a little bit on the genetics, what we know about the genetics and susceptibility to COVID-19 and or flu, I guess. That may not be applicable.
Yeah, sure. So I guess, if we start with what we know, we do know, as Alyssa was mentioning before, that some individuals through just bad luck have been born with errors in their immune system. So they have mutations in genes that are really important to help them fight viral infections. So these people are at higher risk of viral infections. And when they do get viral infections, they have much more severe disease. So a lot of these genes are involved in what we call the innate immune system. And this is part of your antiviral defense mechanism. And they produce chemicals like interferons, which are really important for preventing viral replication. So it's probably going to be the case that, this is a pathogen that the entire world has never seen before, at least the human population in the entire world hasn't seen before. So it's going to place a selective pressure on the population, and those individuals with these susceptibilities to viral infections will declare themselves when they do get exposed and get infected by becoming really very sick. Now, it's going to be very hard to tease apart who those individuals are, because it is as Alisa mentioned, a very deadly virus. I mean, its mortality rate is way higher than the seasonal flu. And so trying to pick out who is the unusual individual who we would not have expected to die is going to be very difficult. But there are two very, very large global consortium that are taking this sort of mammoth task of trying to understand what it is about the individual that makes them more susceptible to viral infection, and particularly COVID-19, and more importantly, why they get severe disease. So those two, one involves, they take completely different approaches. One involves trying to find a single gene that might be important, and the other one is trying to find multiple genetic factors that might impact on that. And we're really lucky at the Garvan because we have two incredible researchers who've had major contributions to both those spaces working at the Garvan. So Daniel MacArthur, who's been a major driver of understanding the human genome in health and disease, is intimately involved with understanding the role of multiple genes in disease. And Stuart Tangi, who's had major contributions to understanding the role of individual genes in how they contribute to immune diseases and antiviral immune responses are involved there. So a lot of those things are in the early days yet. And the hope really is that by understanding what drives the severe disease in these individuals, we might be able to get a handle on things that are not working so well in those individuals, and therefore might give us a drug that we might be able to pull off the shelf, hopefully, and give to people who are suffering from severe disease.
Thanks, Tree. And is Garvan playing a role in these international efforts?
Yeah, absolutely. So Daniel and Stuart, but also a whole bunch of other people are very intimately involved in working with this, and not just the Garvan, but St Vincent's Hospital, the University of New South Wales, and the whole of Australia. We're recruiting patients who we think might be that odd person who you wouldn't expect. So for example, we know that people who get severe disease are the elderly, patients with comorbidities. So if you have a really young individual with no comorbidities, who's absolutely healthy, who gets floored by the virus, you might suspect that they may have a genetic defect that hasn't been recognized yet. So we're sort of like on the hunt, so to speak, trying to identify these individuals so we can study their immune system and study their genetic makeup.
Fantastic, Tree. That sounds very exciting. I'm going to move now to the live questions. The first one I'm going to give to Alyssa. What impact will COVID-19 have on patients with missing enzymes in their complement systems?
Oh, look, that's a really great question as well. We've been really worried about our patients with all types of immunodeficiency, and we've, in Australia, we've been closely following the literature that's coming out from overseas, because locally we haven't, fortunately, had a lot of COVID-19. So, these immunodeficiency disorders like complement deficiencies are really, really rare. And so it's really hard to know from what's coming out whether or not COVID-19 really affects people with immunodeficiency worse or better. We just really don't have the answers to that. But despite the few numbers of patients coming through with immunodeficiencies, so far there hasn't really been a strong signal that patients with immunodeficiencies are doing worse. But because we still are concerned and we're not confident that we have enough data to make clinical decisions based on that, we're still very careful and in terms of recommending strong social distancing and hand hygiene. So with specifically to the complement disorders, I'm not sure that I've seen any specific information about those disorders, but definitely there are local and international efforts in collecting that data.
Thanks, Alyssa. Tree, for you, please, what happened in Melbourne to cause this second wave of COVID-19, in your opinion?
Are you asking me because you know what I think of Melbourne coffee compared to Sydney coffee? No, look, I think that's a really interesting and really important question. And it's one that's you know, I think a lot of people will speculate on, and it's really important that if you're going to buy into that speculation, you don't do it with your sort of biases and your prejudices, because I think, you know, a lot of people in the public domain use it as reasons to push one agenda or another. I think the reality is that, you know, there's a lot of luck involved in a lot of this, but I think one of the problems that we've realized is that COVID-19, a lot of it's actually been imported. And at least in Australia anyway, it's from people from overseas. And in this instance, we have a lot of people coming back from overseas, from countries where there's a lot of COVID-19. And in fact, most of our positive tests have come from these returned Australians. Now, the problem, one of the problems I think in Melbourne has been that they've been quarantined in hotels, but the staff in these hotels haven't really, you know, the sort of procedures that we've put in place at the Garvan have been fantastic. Everyone's very much aware of not just social distancing and hand hygiene, but also the importance of surface contact, making sure that you don't spread infection by touching and cross-contaminating. Now, I don't think that sort of training has really happened, because a lot of the cases in Melbourne have come from hotel workers who've then gone out into the community. So the other thing I think is a bit of a worry is that, you know, sometimes complacency creeps in. And there's a very real risk that as the reproduction number rises, particularly in Melbourne, that we're going to be, you know, in the same place we were only a few months ago. So I think it's, as you say, a really good wake-up call. But I don't think there's any particular reason. I mean, my personal reason is because the coffee is better in Sydney than Melbourne. But
you're starting a war there, Tree. That's great. Thank you. Tree, I'm going to give this one to you again. The bacterial disease hemolytic influenza was, I don't know if I've pronounced that correctly, was present in people who died from the Spanish flu and the Russian flu. Do you also test for the presence of such infections in people with COVID?
Yeah, that's fantastic. A fantastic question. So we do know that patients with these respiratory viral infections, they can get a super infection either with another virus, as Alyssa mentioned before, or with a bacterial infection. And definitely, you know, we would be testing patients for all these things. The presentations may be slightly different, but the important thing is that we make sure that we exclude all the additional things that might be impacting on the severity of disease.
Thank you, that's great. Alyssa, one for you. Are asymptomatic people with COVID-19 immune? Could some people be immune to this virus?
So we don't know why some people are asymptomatic when they get coronavirus, but definitely we know that these people exist. And it could be a combination of factors in terms of, with any infection, it's a combination of factors in terms of why some people are symptomatic and why other people are not. And so it would be, you know, features like the amount of virus they were exposed to and the type of immune response that they're having. So I don't think that we can say that the asymptomatic people are immune, but certainly there is something happening in those people, we suspect, that makes them less susceptible to have clinical disease. And of course, the other thing I mentioned previously was the genetic factors as well. And so part of that research that we're involved in at the Garvan is to determine why some people, you know, really are at the one end of the spectrum, so very severe disease, compared to other people who are, you know, the opposite end of the spectrum would be asymptomatic.
Thank you for that. Now, I'm just going to make a quick mention to our wonderful audience members. There are a couple of earlier questions here that I do believe we've covered in the talk, so I'm going to skip over those if you'll forgive me. The next one, Tree, is for you, and it's a specific request for you to comment on IgA deficiency, given the respiratory complications of that Ig factor.
Right. So IgA is
from your lab. Is that a plant from your lab?
You'll never prove it. So IgA is a type of antibody. So there are different types of antibodies that the body makes. The commonest is IgG, but IgA is really, really important because it's the antibody that gets secreted into our mucosal spaces. So it's in our lungs, it's in our gastrointestinal system, and it prevents the bacteria and viruses from breaching our initial defenses. So there are, as the audience member mentioned, individuals who don't make IgA at all. And it's really difficult to know for sure, you know, what happens with these individuals in terms of their risk of infections. The feeling is that because they don't make IgA, they would be at greater risk. But one of the things that we're sort of discovering is that in the absence of IgA, some of the other types of antibodies can compensate for it. Now, with COVID-19, one of the really interesting things is that the people who are getting very severe, getting very sick and they have an exaggerated immune response, and they very, very early on, much earlier than we would normally expect, are making not only IgG, but also IgA antibodies. And the ones making large amounts of those antibodies, actually, surprisingly, paradoxically, the ones who are actually getting very, very sick. So that's my sort of long-handed, hand-waving answer way of saying we don't really, really know. But I suspect that, you know, as Alyssa mentioned, we've been very careful in monitoring and scrutinizing our patients with immunodeficiencies, including patients with IgA deficiency. And there hasn't been a spike in cases of COVID-19 or even severe COVID-19 in these individuals. So we suspect that probably they're not at the risk that you would imagine they would have.
Thanks, Tree. That's great. Sara, for you, please. I was treated for breast cancer 5 years ago. With chemotherapy, my WCZ zeroed. Since treatment, I've had more frequent and more serious infections and feel this could be related. Is there any research in this area?
Not as far as I know, and I think there could be other reasons perhaps why you have more or you particularly have more infections that may not be related to the treatment that you had 5 years ago, because that's a very long time ago. And, you know, from what we know, the immune system does recover. So there could be other reasons why you might have severe infections, whether or not you've got other coexisting medical conditions, like that was mentioned before by our panel members, that can make you sort of immunosuppressed. So there could definitely be other reasons, but I would not relate that back to the treatment that you had that long time ago.
Thanks, Sara. Alyssa, for you, please. Should one stop taking methotrexate for rheumatoid arthritis during the pandemic, as it seems to have a negative effect?
Sure. Look, during the course of this pandemic, I've had similar conversations with lots of my patients because a large proportion of them are on immunosuppression. Really, the advice we're giving at the moment is that all patients should continue to be treated for their autoimmune disorders, and that's advice from all of our leading societies, including the Australasian Society for Clinical Immunology and Allergy, for example. So far, we don't have a strong signal that patients who are immunosuppressed and treated are doing worse from COVID, as Tree mentioned. And we're also concerned about the consequences of stopping medications. But really, this is a question that you need to discuss with your own individual care provider, because some of these decisions are very individual and really depends on your other risk factors as well, and how your disease is going. And so we try and tailor how we treat patients, you know, whether it's the risk of COVID or other risk factors, depending on a whole host of different factors, and really it's really individual medicine. It's really taking into account your own personal risk factors and situation.
Thanks for that. Tree, is a countrywide implementation of mask and gloves possible instead of lockdown and physical distancing?
Yeah, look, so that's a really difficult question, and you've really put me into it now, haven't you? So one of the things that you know, masks do is that it's very good of protecting not the person wearing the mask, but the person not wearing the mask. Because if a person is infectious and can spread the disease and they have a mask on, that significantly reduces them spreading the disease. Now, I think one of the really interesting things, not just from COVID-19, but from experience with other things in the past, is that quite often there are measures that seemingly make a lot of sense, but actually the physical implementation and execution of that idea doesn't work as well. And part of the problem is that it creates a false sense of security. So in this instance, masks need to be really carefully fitted. They need to be appropriate for the risk in terms of the exposure that individuals placed under. So, you know, in a situation where you've got literally, you know, like a very, very high prevalence of disease, for example, you know, if you look overseas to some of those countries like New York a few weeks or months ago, Italy, in Europe, in those situations where there's very, very high prevalence of disease, then yes, definitely I would think the balance shifts to what the use of widespread use of masks. The problem is that I don't think a mask, and the data, the modeling and so on, doesn't quite support the fact that it can replace social distancing. Social distancing is far more effective. And in addition, I think there's that awareness that gets put in place, and you don't have that complacency that, oh, I've got a mask, so I can sit close to you. So short answer is no.
So no hugs for a long time. That's sad news.
I'm sorry.
Alyssa, one for you, please. My adult daughter has a PID, so primary immunodeficiency disorder. Are there any things she can do to improve her immunity other than sleep, exercise, and nutrition?
So yeah, so improving immunity is like the holy grail, I guess, of treating patients with immunodeficiency. I think the best thing you can do if you have an immunodeficiency is firstly to be very adherent to those social distancing measures and hand hygiene, and also stick to your therapies. So the way we treat some immunodeficiencies, for example, is through things like immunoglobulin replacement therapies. In some people, that has to be given by an infusion, and it involves attending hospitals. And I know we've had lots of patients who've been concerned about coming to hospitals. So if that's your situation, I'd strongly encourage that you speak to your care provider to make sure that that situation is as safe for you as possible. We're doing a lot of social distancing within the hospital. There's also the option of converting to subcutaneous immunoglobulin therapy, for example. So there are options to improve your protection, but unfortunately we don't have that magic bullet where we can boost people's immune systems. You know, you see a lot of things like immunity tea out there and all of that, but at the moment we don't have anything that we know really works that we would be recommending to people.
Thanks for that. And another very practical and important question this time for you, Sara, please. Oncology patients who have chemo often have a runny nose due to hair loss. If they are otherwise asymptomatic, what should they do? Would they still be allowed into the hospital or into the Kinghorn Cancer Centre? Would they have to get tested for COVID-19?
Yeah, so usually they get a runny nose or a bit of blood when they blow their nose, mostly because chemotherapy actually dries out your mucous membranes, which is the little fine sort of mucosa that sits particularly in your respiratory tract. And your nose, in particularly during times like this, when the air is also relatively dry to summer, say, it definitely gets more runny. So I usually recommend my patients to just use normal saline nasal spray to try and kind of moisturize the respiratory tract. But, you know, if it's just a runny nose to secondary to chemotherapy, and there's no other associated worrying symptoms, then we still let these people through if it's just, you know, related to that, which is, you know, relatively, we can be relatively confident when that's related to chemotherapy versus something else at this point.
Yes, and just to reiterate, we are temperature screening everyone entering the Kinghorn Cancer Centre and the chemotherapy suites there. Now, I do apologise, we are running very short of time and there are more questions than minutes left. So I'm going to come to perhaps just one final question for you, Tree. How long will it take for COVID-19 antibodies to get into immunoglobulin therapy? The magic question.
Right. So I'm just trying to understand this question. So immunoglobulin therapy, what we do is we collect blood from donors and we pool them and we prepare the antibodies, the IgG from that, and we give that to patients who can't make their own antibodies. Now, for that pool to contain anti-COVID-19 virus antibodies would require that the donors have been exposed and make antibodies to it. So in Australia, I just don't think that's going to happen. Luckily, we really are very lucky here, because I don't think we have the sort of disease, the level of exposure that other countries have had. Separate to that, though, there's been huge endeavours both locally, and the Garvan Institute's been a part of this through Daniel Chris and Chris Goodnow, together with Tony Kelleher and people at the Kirby Institute at UNSW. There's been a concerted effort to try and develop what we call hyperimmune immunoglobulin, where you take people who have been infected and have recovered from COVID-19, and you look to see if they have enough antibodies in their blood, and then you collect that and you isolate and purify that, and then you give that to patients. And that's been trialed overseas with some success. And that's a collaboration through CSL, which is an Australian biotech company, whose director happens to be John Shine. It sounds like I'm doing a plug. Anyway, I think, and the idea then is that those preparations would then be used for people with very severe disease. And that's certainly looking encouraging, and hopefully maybe, the trials will be completed in the next few months, and there will be rollout of that. And then the final way of doing that is actually to engineer an antibody, to actually, create one that's designed to specifically target the virus. And again, that's something that the Institute's been actively involved in trying to do.
Thanks, Tree. Fantastic. Now, apologies, everyone. We are at time, or just a little bit over. So on behalf of the panel, we thank you very, very much for joining us this morning. Some really fantastic, astute questions there. So we really appreciate your time and your participation. As always, we look for constructive feedback so that we can continue to improve our public seminar series, albeit virtually at the moment. So there will be some questions, some seeking feedback coming up on your screen shortly, and I would really encourage you to give your full and frank feedback there. We will be back again in July with the next seminar via Zoom, so please keep an eye out for that. We thank you so much for all your support, for your interest, and if Chris were here, he would encourage you to continue physical distancing, but not social distancing. He would say, stay well, stay safe, and stay sane. And on behalf of everyone at Garvan, thank you. We'll see you soon.